he has no inoperable small cell lung carcinoma, having had palliative radiotherapy. He has a 65 years smoking history. On examination, he has oxygen saturation of 83% in air. He is apyrexial and has a respiratory rate of 26. He has reduced air entry throughout the left lung as well as downward to percussion and reduced lung extension. A chest X-ray is requested to assess for progression of the known lung tumor and possible secondary complications such as collapse of ventilation. X-ray of a 52-year-old male. Rotated to the right. Adequate inspiration and penetration. Inadequate exposure. Trachea appears slightly deviated
To the right.
to the right.
Because of the rotation.
Because due to the factoring in the rotation, there's no deepening of paratracheal stripe. Mediastinum appears to be central within the rotation with no widening. Carina's play is normal.
Actually, I could hardly see any. It's difficult for me to ascertain the carina. This, but this, sorry, to be, I think it's slightly widened, but on my eyeballing, okay lah, tapi it's not widened. So this one is right. Okay.
There's no upper lobe dilation. There is reduced lung volume over the left side with crowding of ribs over the left.
So there's reduced lung volume on the left side. So what's your take on that? Huh? What color? So what is the features of left upper lobe?
One will be reduced lung volume, and then on the hilum will be pulled upwards, crowding of ribs, loss of cardiac.
What is the characteristic of left upper lobe?
Veil-like
Veil-like opacification. Veil-like opacification is the hallmark. Nombor satu, nombor dua.
loss of lung volume.
Okay, lost lung volume. The lung volume lost in collapse. Crowding the ribs, general. Specific for, you could say hilum will be pulled out. But specifically for the left upper lobe collapse, what is the hallmark? Veil-like, nombor satu, or Clambu-like, whatever you want to say. One is loss of cardiac border. There's no cardiac border can be seen on the left side. You obliterate the left cardiac border, gone. Where you see the chest X-ray where left cardiac border is gone, so this suspect left upper lobe collapse. So volume loss, crowding ribs, the pull up of the hilum, diaphragm is markedly pulled up. Okay, by right, the right should higher with the left now. It's already pulled up. Gone, cardiac ribs. Plaque atelectasis, and this is at the level of the hilum. So they call it what? Perihilum? Mass. Okay. You can see a well circumscribed perihilum mass. This known inoperable of the okay. ABC.
They are unable to comment regarding cardiac injury. No electrocardiac resuscitation seen. There's no air under diaphragm. The left under diaphragm is severely elevated. No blunting of postophrenic angle. Normal control of the diaphragm. No extra seen. Unable to visualize the left. I think both the cardiac border not clearly seen. I think the right side is because of the rotation.
Yeah, this this still can be, you can comment. But the left is you can't.
Obliterated.
Mm.
Left heart border is obliterated.
Mm.
And gastric bubble is in. Hilum, as mentioned, there's a well circumscribed mass over the left hilum.
So what do you comment about hilum? Right, size, shape, position, and lumpy bumpy. So what do you know?
The right hilum appears to be
Lumpy bumpy.
right hilum is
Lumpy bumpy, right?
The hidden areas effects seems to be clear. The hilum for the mass, retrocardiac uneven comment,
You can actually comment on this right retrocardiac.
right retrocardiac.
Looks clear, except for this part. This mass, this hilum mass, or bulky hilum. Dense, bulky hilum.
Image skeleton appears to be normal and soft tissue unremarkable.
Cytokinesis. Left,
Left,
upper the collapse, left hilum mass.
left hilum
With
mass
hilum.
complicated with left upper collapse. So patient rotated to the right, apparent tracheal division likely due to patient rotation, clear right lung, bulky dense right hilum, hazy wheel-like opacification of the left hemicurate, large left hilum mass, linear atelectasis, elevated left hemidiaphragm.
Right.
Left upper lobe collapse. Patient ID anonymous, projection PA, adequate penetration, inspiration, and patient introgated to the right. Airway, the trachea is central after factoring in patient nutrition. Bleeding, there is a hazy wheel-like opacity in the left hemiplex. A linear opacity is present in the left lower zone, consistent with atelectasis and is left-sided volume loss. The right lung is clear and not hyperinflated. Pleural spaces are clear, normal pulmonary vascularity. Circulation, the heart size and cardiomediastinal contours are difficult to assess due to patient mutation. The mediastinum is projected to the right, which is probable due to the patient mutation, and aorta appears normal. There's a rounded mass projected over the left hilum. Hilum itself is normally positioned. The right hilum appears bulky and abnormally dense, but in a normal position. Diaphragm and delicates. The left hemidiaphragm has a normal curvature but is markedly elevated. Normal position and appearance of the right hemidiaphragm. No pneumoperitoneum. Image skeleton is intact with no fractures or destructive bony lesions visible. Visible soft tissues are unremarkable. Express and review areas. No vascular lines, tubes or surgical clips. Lung incisors. Left apical opacification. Normal right effects. Left hilum mass. Bulky dense right hilum. Behind the heart, postoperative angles and below diaphragm is normal.
I do contest the hilum on the left side. To be honest, the hilum on the left side, I think that the right should be lower than the left, right? Okay, but tarik banyak, so you see it is a bit more higher as compared to normal position. I contest that. Okay, and left. You contest the left apical opacification. You didn't mention. It's actually very light, right? You can also mention, right? You can also mention that, right? I mean, I want you guys to be familiar with this left upper local line. Okay, so the standard teaching is very light opacification, volume loss features. Volume loss is characteristically present or lung collapse, crowding ribs, hilum, mediastinum, diaphragm. But what is characteristic of this particular left upper local collapse? Very light opacification and loss of left cardiac volume. Right, so this actress demonstrates a left upper local collapse. Yep.
this X-ray demonstrates a left upper lobe collapse, like opacity of the left hemithorax, likely secondary to the left hilar mass. There is associated volume loss demonstrated by the markedly elevated left hemidiaphragm. The right hilum is also abnormal. The apparent linear sinus shift to the right is probably due to patient rotation. The most likely cause of collapse is secondary to the left hilar mass. Other differentials for collapse such as mucus plugging and an inhaled foreign body are unlikely. Supplementary oxygen should be given. Initial blood tests may include FBC, urea,
Electrolytes,
electrolytes,
LFTs.
LFT, bone profile, and CRP. The X-ray should be compared with previous imaging to assess progression. An up-to-date CT chest and abdomen with IV contrast may be needed for further assessment of early staging. Discussion with respiratory and oncology for further palliative treatment will be necessary.
Now what? Where you see collapse? Intraluminal, extraluminal. So most I've seen those associated with asthma, they presented with collapse. I think last time we had one patient of pregnant lady came into us and collapsed so bad, and he turned out to have right upper lobe and the middle lobe collapse. And in an asthma, mucus plugging. Okay, in elderly, most probably extraluminal. Okay, so we've seen quite a number of left upper lobe collapse. Right?
For esophageal cancer. Over the last 24 hours, it has become increasingly difficult to ventilate through his tracheostomy. The chest X-ray the previous day to assess lying position showed clear lungs. A further chest X-ray is requested to look for possible reason for this deterioration, such as pneumonia or pneumothorax.
So the guy had this guy had the surgery, and previous chest X-ray was clear. So this chest X-ray requested again, so the guy had increasing difficulty to ventilate. Okay.
This is anonymous chest X-ray, AP view, AP semi-supine view, not rotated. Inspiration, penetration poor, and
Penetration not suboptimal, right?
suboptimal. And then exposure, suboptimal exposure. So airway, trachea central, normal carina square, and no paratracheal thickening, paratracheal strip thickening.
Strike.
No, strike thickening, and no widening mediastinum central. D is upper lobe diversion.
Mind you, this guy. Yeah. Of course, you would like to comment on vascular marking. Vascular marking in this case, the guy had acute deterioration of lung function. Previously clear, now suddenly become like this. One differential will be acute heart failure. Another differential will be pneumonia. So what type of pneumonia? So pneumonia, this this is bad pneumonia because it's all white. Now, the increased pulmonary vascular marking dengan what we call it interstitial thickening, opacification, almost sama dekat sama. But okay, so you say upper lobe diversion, dia upper lobe diversion dia naik banyak, tapi dia gelap. Dia naik, you can see, but you will see more gelap, surrounding gelap. So this is more putih banyak ke gelap ya? Putih banyak. So this putih banyak could probably represent of interstitial opacification. So vascular marking, probably vascular marking you can say is, what is, there's two types of consolidation. One is called airspace, another one is called interstitial. Okay, So airspace obfuscation or consolidation, you make conclusion it is consolidation. How? This consolidation, satu putih, dua, it obliterate, summary, vascular marking. Tiga, it appears like a cotton-like, wool-like, or cloud-like obfuscation, consolidation. Interstitial, macam mana interstitial? And Mak Saleh give, because it looks like that, they call it lace-like obfuscation. Okay, so this is actually the anon vessels. So this lace-like obfuscation with patchy airspace obfuscation, and you can actually see inside air bronchogram. What? Air bronchogram. So this description for upper lobe diversion is only for acute heart failure. You know, that you say ST elevation, of course, ST elevation, there are 6 causes. But predominantly when you say ST up, you are saying, MI. Mana MI? Was there is ST up, but this is not ST up of MI. Okay, this is something like that. But, okay, with heterogeneous, patchy, what? Scattered bulla. Patchy, heterogeneous obfuscation of airspace. This just actually want to tell you ARDS. Okay. What is ARDS? ARDS is actually non-cardiogenic pulmonary edema. So you cut the upper lobe diversion. I'll try to say, if you want to say ARDS, you don't say upper lobe diversion. Yep. Banyak. Extra. Satu, what is this? Tracheostomy. Ni? Chest tube. Di sentinel eye. It's inside. Tengok sentinel eye ada 2. Dia ada 3 lubang actually. Depan satu lubang, tepi ni satu lubang, sini satu lubang. All inside the lung field. Okay, Malaysia punya chest tube ada satu lubang yang kat depan. Kat depan ni lubang ni, lubang kat depan ni. Ada tepi satu kan. Betul? So sentinel eye dia satu kan. You just have only one sentinel eye. Mak Saleh punya ada 2. Actually 3 sentinel eye. 1, 2, 3. 3 lubang. One block, there's another block. Another one block, there's satu. So actually, when you measure, when you put the chest tube, sini ke sini should be measured, and sini ke sini should be inside the lung field. So you push. So how much you're going to push your chest tube? I push chest until my 2 sentinels inside the lung field. Jawapan dia should be like that. So my 2 sentinels should be inside the lung field. But I can't say 2 sentinels in Malaysian when you chest tube. So send 1 sentinel inside. Okay. And you baca radiology punya report, dia say the tip, always to comment, the tip is projected. Projected where? You can counter it. Okay? You can counter it. 1, 2, 3, 4. Projected there. Positioned at that tree. On the right side. They are always very important for them for the chest tube, projected way. And then this, kalau you remember the aku remember surgical tu dulu lah. Esophagectomy, either you anastomosis in the neck or anastomosis in the chest. Yeah. This one, the surgical, the esophagus is anastomosis in the neck. So you see the surgical bit. And this is the ECG leads. This is the small central. Huh? Breast tube. The tip aku tak nampak. Ni ke? Ada lagi? Ada lagi bawah? And the tip here. Okay? Huh?
JC.
And this? This. This is the coil of the Coriolis. And what is this? Extra? F?
Left hemidirect of obliterated.
Yeah.
Others right and left cardiac model normal and right left hemidiaphragm normal, right hemidiaphragm model is obliterated. Okay. Right ventricular CT also. F, G,
Bubble or C?
no S, H, higher, which is right, is lower than that. Normal shape and
Side shape position looks normal. Density also looks okay. Persication. Right. With the style looks okay. To be honest, because it's under penetrated filler. I don't know whether this
opacity
or there is retrocardiac oscillation on the right and the left. I don't know.
penetration. But then I emissions, sufficient skeletal, normal intact.
The image skeleton is there.
Okay.
No obstructive ovulation.
Right interlinear line, ECG lead, tracheostomy, subtle rays like interstitial opacification, intercostal chest drain, clear right border, patchy airspace opacification, lateral part of right hemidiaphragm is obscure, surgical clips, subtle rays like interstitial opacification, central trachea, surgical clips, no evidence of cardiomegaly, patchy airspace opacification, clear left heart border, normal left hemidiaphragm, nasogastric tube. Acute respiratory distress syndrome. Patient ID anonymous, projection portable episemisupine, penetration slightly underpenetrated, vertebral body is not visible behind the heart, inspiration adequate, 6 anterior ribs visible, rotation not rotated.
I know for a fact that Najwa told me lah. The ED packets all brag lah. Because Najwa dia buat mana? Posting dekat NSI. Dia kata when it comes to chest X-ray, CG like this, the ED guy was like confident lah, you know. At least the ED guy will be confident of the ECG, we go in chest X-ray. Because it's the thing that we use already, right? So kalau buat rotation, dia kata, okay boss. Pre-op assessment, post-op assessment, ICU, chest X-ray, easy peasy.
Airway, the trachea is central, breathing, there is diffuse heterogeneous airspace opacification throughout both lungs, Bilateral interstitial opacification is also present.
Yeah, the one pull up is air space. You know, opacification is two types. Air space and interstitial. Huh?
The lungs are not hyperinflated. The pleural space are clear. Normal pulmonary vascularity. Circulation, the heart is not enlarged, even allowing for the magnification caused by the AP projection. The heart borders are clear. The aorta appear normal. The mediastinum is central, not widened with clear borders. Normal size, shape and position of both hila, diaphragm and delegates. The lateral aspect of the right hemidiaphragm is partially obscured by consolidation. Normal appearance and position of the left hemidiaphragm. No pneumoperitoneum visible, although this is difficult to assess on a semi-supine X-ray. The image skeleton is intact with no fractures or destructive bony lesions visible. The visible soft tissues are unremarkable. Extras review areas. Tracheostomy in situ, with its teeth projected above the carina. An external device, likely related to the ventilator, is also visible. The tip of the right internal uvular line is projected over the mid SVC level. Injective in situ, although the position of its tip is difficult to identify. Right intercostal chest drain, the tip of which is projected over the right upper zone. ECG monitoring leads in situ. They are surgical clips projected over the mediastinum and extending from the sternoclavicular joint up towards the neck in keeping with the recent surgery. Lung episis, interstitial opacification of the lung episis. Hila normal, behind heart normal, postrophrenic angle consolidation at the right postrophrenic angle, below the diaphragm normal.
Yeah, dia kata behind heart normal. Okay. But it's underpenetrated, suboptimal penetrative film. Okay. Alright. So,
Summary decision management. This X-ray demonstrate patchy airspace consolidation and interstitial opacification. The differential diagnoses include ARDS, pulmonary edema, and a typical or severe pneumonia.
okay.
Concerning the rapid appearance of the changes, the distribution of findings, the recent surgery, and the lack of biochemistry.
The differential diagnosis include ARDS,
Yes.
pulmonary edema. See, when you see the pulmonary edema, how do you comment the lung normal pulmonary vascularity? You see, whereas APO will be upper lobe diversion. Considering the rapid appearance. Great.
The patient needs supportive care including ventilator support. The patient's oxygenation and ventilation status should be monitored with regular arterial blood gas sampling. Initial blood tests may include FBC, urea electrolytes, and CRP. Antibiotics should be given if infection is suspected or confirmed. An echo may be useful to assess left ventricle function. Serial chest X-ray should be performed to assess response to treatment. Adult respiratory distress syndrome (ARDS), severe unexpected acute respiratory distress, usually requiring mechanical ventilation, that develop in a patient with no major underlying lung disease. Diffuse alveolar damage from increased pulmonary capillary permeability, which develop in response to numerous types of lung injury and result in leakage of proteineous fluid into the alveoli. This process eventually result in alveolar destruction and hemorrhage, a reduction in surfactant and alveolar collapse. Causes include diffuse severe pulmonary infection, bacterial or viral, prolonged or profound shock, inhalation of toxin and irritants, oxygen toxicity, systemic reaction to a broad spectrum of non-pulmonary process. Diagnosis is based on clinical grounds, acute onset of bilateral lung opacities, no clinical sign of congestive period, pulmonary artery wedge pressure less than 80, partial oxygen FI2 less than 300, high mortality rate of up to 60%.
What call it? PF ratio. Okay.
Less.
Less than 300. Okay. ARDS is basically okay lung, sudden onset. Okay lung, sudden onset. Marked lung opacification. And ARDS is by name itself acute. acute respiratory distress. Common causes can be of non-pulmonary problems. You can have pancreatitis ARDS. You can have burn ARDS. You can have inhalation of something toxin and ARDS. So you can have COVID and ARDS, right? ARDS, and the hallmark is no evidence of heart failure. I mean, if you do echo, left lung contractility good, you do your pro-BNP or BNP is not elevated, and chest X-ray, wow, throat, and it's a mixed picture between interstitial and airspace. And the diagnosis is always based on clinical grounds. Kalau tanya you, macam mana you diagnose the ARDS? Or tanya you, how do you diagnose the ARDS? Clinical, chest X-ray, P average. Simple. So some buggers are going to ask you in medicine, Viva, how do you make a diagnosis of the ARDS? Number one, clinical. Two, based on the story. Usually XR, pulmonary, echo, chest X-ray. You can't have a clear chest X-ray, you see ARDS, cannot. It's 4, devoid of any evidence of heart failure. 5 will be P average. And the magic number they want you to memorize is? Less than 300. That is the magic rate number. So meaning PaO2 in millimeter mercury, FiO2 in millimeter mercury, yeah. Less than 300. All in millimeter mercury. Okay? 300 mortality. So I think that much you think. You say one bugger come and bad chest X-ray, boss bad chest X-ray, boss. Think if you have a guy who is well and suddenly become like that, you think, oh, this is the ARDS, and ARDS could be extra pulmonary problem. It can be problem as well, like pneumonia, bad pneumonia. Okay? That's why I remember ARDS for emergency guy. You know, those who take up critical care stuff, they will definitely ask in the life. So remember.
A 76-year-old female presents to ED with chest and shoulder discomfort following a mechanical fall. There is no significant past medical history. She is not smoker. On examination, she has saturation of 100% in air and is febrile. Her RR is 16 with a heart rate of 82 beats per minute. Lungs are resonant throughout with good bilateral entry. A chest X-ray is requested to assess for possible rib fractures or a pneumothorax.
So the guy is 76-year-old, mechanical fall. Aku suka ayat the mechanical fall, cuy. Mechanical fall. Alleged fall, you say mechanical fall. Or mechanical fall. Okay. So trauma case, huh?
Chest X-ray, AP erect, not rotated, good inspiration, good penetration, inadequate.
Adequate penetration lah. Ada good sangat tak lah. Tapi you can see the disk space. And retrocardiac you can see the disk space lah.
Adequate penetration, inadequate exposure.
Yep, correct.
Trachea is central. Normal.
Central
mediastinum.
No mediastinal tract thickening.
No mediastinum.
No prior tracheal tract
thickening. Normal.
Prior splay looks okay.
Normal.
Then mediastinum not widened. Whether central or not.
Central. Normal pulmonary vascular marking.
Okay. Kalau orang tanya aku what is this cranial thing? This? Mana looks then? Okay.
Normal costophrenic angle.
No, you would say normal pulmonary vascular marking. You see normal primary vascular marking, what you mean there's no heart failure, right? The moment you see heart failure, it's not normal cardiovascular marking. At least you see that there is upper lobe diversion, right? It's a normal primary vascular marking.
C, no cardiomegaly, no
Aorta,
aorta, normal.
so slightly unfolding.
Unfolding of aorta.
Yeah, unfolding the aorta, right? Yeah, done it, unfolding.
D, no metastatic, no air under diaphragm.
Ni apa dia ni? What colour? What we call it? A buffalo? A buffalo half. Benda what? At abnormal diaphragm, you can have irregular diaphragm. What we call it? Huh? Scallop, yeah, scallop. No one. Huh? Abraham or normal line? Eventration. Alright. Eventration, alright. Eventration of right hemi diaphragm is typically it's a normal thing, but usually because it's the diaphragm is all muscular, some part of it is replaced by fibrous tissue. So you can see a hump. They will call it diaphragmatic hump or eventration of right hemi diaphragm. It's 76 years old.
No extra. For cardiac silhouette C. No gastric bubble C.
What kind of
Oh, ada. Gastric bubble C. Normal bilateral hilum. No lumpy bumpy. Normal position.
size, shape, position,
Normal size, shape,
and no
density.
lumpy bumpy.
No lumpy bumpy hilum.
Hidden area.
Bilateral apex normal, retrohilar normal, retrocardiac normal.
You cannot see the right retrocardiac. Pasal the right border falls on the edge of the spine, but you can see the left retrocardiac, right?
Image skeleton, skeleton humerus, neck of humerus fracture. Right neck of humerus fracture. Rib appears normal. No motor.
Okay. No. Mana you're saying no subcutaneous matter says correct, right? No extra sih lah. Dia tanya Haris, apa ni Haris ni? Hey. Ha? Apa dah Haris? Eh, apa ni? Ha? Tali pinggang. Tu tanya, arm sling. Apa dia tu? Syak, apa dia ni? Ha? Bandage apa kat belakang tu kan? Ha? Aku tahu just variety of brown hook ah. Right? The one that I could see my wife one tu. Most probably lah, the hook, brown hook lah. Huh? Most probably lah. Okay. Variety kan ada kan? There's many types kan? Ada satu, ada dua, ada tiga.
Minimally displaced fracture of surgical neck. Minimally displaced fracture of the surgical neck.
One new comment is very common fracture. You tengok AC joints sekali tau. This do not mean AC joint disruption. This do not mean AC joint AC and DC. AC, this is AC, acromion clavicular, and this is the DC. This is apa ni? Huh? Yeah. CC. Okay. This is AC. So this is. Please look at. So usually AC. Huh?
Clear right lung, clear right heart border, eventuation of the right hemidiaphragm,
Eventration or right hemidiaphragm to work, or diaphragmatic harm, and then later.
central trachea, clear left lung, unfolded thoracic aorta, clear left heart border, normal left hemidiaphragm. Patient ID anonymous, projection AP erect, penetration and inspiration are adequate, rotation, the patient is not rotated. Airway, the trachea is central, the lungs are clear, the lungs are not hyperinflated, the pleural space are clear, normal pulmonary vascularity. The heart does not appear enlarged, although its size cannot be accurately assessed on an AP X-ray. The heart borders are clear. There is mild unfolding of the thoracic aorta. The mediastinum is central, not widened, with clear borders. Normal size, shape and position of both hila. There is eventuation of the right hemidiaphragm. Otherwise, normal appearance and position of the hemidiaphragm. No pneumoperitoneum. There is a minimally displaced transverse fracture through the surgical neck of the right humerus. No other fractures or bony lesion. The visible soft tissues are unremarkable. No vascular lines, tube or surgical clips. Lung episis, hila behind heart, costophrenic angles and below diaphragm are normal.
Okay. So this X-ray I'll show it to you because I don't want you to miss the fracture. Okay. No, see the image character is that until you look at it, it's really there. I want to miss the fracture. I want to miss AC joint disruption. I want to miss that. Okay. And I want to show the eventuation of right hemidiaphragm. I think I've discussed it in the very beginning. Right? You can see scalloping, you can see diaphragmatic harm or eventuation of right hemidiaphragm. I want to show this. I want to show sometimes you can see this and you thought there is a pneumothorax. It's actually not. Actually, this is part of the diaphragm and something like that. Not all derivation. Okay? We show this for you. And unfolding data.
Case 67, an 80-year-old female present to ED feeling unwell with pyrexia and productive cough. There is no significant past medical history. She is a non-smoker. On examination, she has a saturation of 93% in air and is febrile with a temperature of 38.2. There is dullness to percussion, reduced entry and crackles in the left mid-zone.
Mind you, crackles in the
Left mid-zone.
left. You pakai crackle ke crepitation?
Reputation.
Crack lah. So this stimulation. Okay. Buat crackle malah lain sikit lah lain kali. Crackles. Okay.
A chest X-ray is requested to assess for possible pneumonia.
So this all, I mean the probable pathology will be on the left.
Left. This is anonymous chest X-ray. PA erect. Not rotated. Adequate inspiration, penetration.
The rotated. Mildly rotated, right? Kalau kata this is kepala dia lah. This is kepala. So this is sensitive. Rotated to the right. Mildly rotated to the right.
Adequate inspiration and penetration, inadequate exposure. Trachea central but deviated to the right towards the end after factoring the
Factoring in the rotation from the central.
otherwise no parietal stripe thickening. Unable to comment on coronary spleen. No widened mediastinum.
You can see the cranium, right? Yeah. Yeah. think probably this area. Tapi tak apa clear kan? Probably this lah. Go.
Breathing normal, no upper lobe diversion. There is
Sorry. You comment on the mediastinum where it is central. Then the outline of the mediastinum is clear. Central. The outline is clear and no widening. Tiga benda kan? And you want to comment sekali terus pun boleh. There is no one for the aorta. Okay. Comment on the aorta straight away on that part. And then you start with B breathing.
there is
No upper lobe
no upper lobe
diversion.
diversion.
All vascular marking loads.
Normal.
Wow.
Normal. There is heterogeneous opacity
Heterogeneous
over the
opacification.
left. Over the
Very
upper-
subtle, right? No, not so subtle for the trained eye now. This
Heterogeneous opacity over
heterogeneous opacification over the right or the left. The left
the left.
lower zone.
The left
Obscuring
lower zone, obscuring the left heart border.
consistent with
Apa ni?
consolidation.
Consolidation of
And the
the
area where this is the pulmonary vascular marking is slightly obliterated. Okay. And there is a
there is a blunted
Blunted
left costophrenic angle.
consistent with small.
Para-pneumonic effusion.
Correct.
Otherwise, there
On
is
the right side.
right side normal. Otherwise, no cardiomegaly. Diaphragm,
The right is higher
the
than the
right,
left, right?
the right.
Nearly to atas sini ke bawah.
The ini sama. And no A under diaphragm.
The right diaphragm and
The right
left
diaphragm,
diaphragm.
the right diaphragm
The
is
border
higher
is clear.
than the
The-
left, and no A under diaphragm. No extra scene. There is obliteration of left cardiac silhouette. Gastric bubble scene. Hidden area. Apex.
dulu, hilum.
Hilum. Hilum. There is apa ni?
right.
Left, right.
Hilum.
Right hilum
It's
normal.
lower than the left.
Left hilum
which is
normal.
normal. The side shape position. That's also normal. Banyak ends
Tu
and
biasa.
arteries, right? Dia duduk macam ni. Now, duduk macam ni. You see it bulat kan? Yeah. And on arteries here. Bulat tu and on artery. What is the dalil? This is the vessels.
Dia over central.
Dia tu central. Right. Dia tu central. Kalau dia tepi, semua normal.
Nodule.
Okay.
Hidden area. Apex, apex and retrohilum normal, retrocardiac, the retrocardiac, left retrocardiac consolidation.
No. What is the retrocardiac ni? Apa dia? What is this? With acid level sometimes. What is this behind the heart? Apa dia was? Ada orang menunjukkan. What is this?
Ni kayak apa tu? Triple calcification kan? Aorta kos?
Ha? Apa tu?
Aorta kan?
Ha?
Abdominal aorta dia bawah lagi.
What's that? Retrocardiac.
Cardiac.
Dilatation of the esophagus.
Rotation of the
Where is it? Dilatation of esophagus. And then the esophagus part dia naik duduk dah kan. Betul tak? That will lose the out. Start with H. Huh? Start with H.
H.
Start with H.
H.
Dia ni dia. Kat lu jawab.
Tak ingat lah. Tak ingat lah bos.
Hernia. What hernia? Itu je. Kak Lu jawab Kak Lu.
Apa dia? Hernia.
Ha? What was that?
Dah bos sudah bagi clue dah.
Clue aku dapat H.
Clue ni apa?
Ha? Start with H-I-A. Here. Higher. Hiatal.
Hiatus hernia.
Ha?
Hiatus hernia.
Hiatal hernia. What hiatal hernia? What's hiatal hernia? Hernia of the
Yes.
you can have hernia. You can have
Hernia,
esophageal
hernia.
actually. Esophageal. And the esophageal part, the gastric part of the esophagus got herniated back inside, up above the esophageal opening, and sometimes this can be dilatation of the esophagus, leading or stagnation of the food material inside. And you can see sometimes airfield level. This is hiatal hernia. The X-ray I want to show, besides this consultation, I want to show the moral, the story of this chest X-ray. I want to show also about the hernia, hiatal hernia. Aku rasa ada previous X-ray pun ada jumpa sekali. Ada one hiatal hernia. The hernia, retrocardiac consolidation of the back. Retrocardiac, but this is well circumscribed retrocardiac with wall. You can see a thick wall, as you can see a gas density surrounding the wall, suggestive of hiatal hernia. Dalil was the evidence at the central. It's a wall, and inside that there's a gas density. So this suggests hiatal hernia. The image skeleton.
Unit skeleton, there is kyphos, scoliosis of the spine,
Yeah.
and
Tidak mudah lah itu.
scoliosis. Soft tissue unremarkable.
Lady or guy?
Lady.
It's a lady. The image skeleton is a stagno fracture disruption. So what is your diagnosis?
Left
Sapien,
SAPI.
left lower pneumonia with hiatal hernia. Oh, really? Apical pleural thickening. Okay.
Apical pleural thickening, apparent tracheal deviation due to patient rotation, clear lung field, clear right heart border, hiatus hernia, gas density, normal right hemidiaphragm, clear right post-pharyngeal angle, patient rotated to the right, apical pleural thickening, clear upper left heart border, left
Just
lower zone
clear upper
consolidation.
left, meaning you are saying the lingula is not affected. But if you say superior or inferior heart border or upper or lower heart border,
Left lower zone consolidation, obscured lower left heart border, small pleural effusion, normal left hemidiaphragm. Report hiatus hernia, patient ID anonymous, projection PA, penetration adequate, vertebral bodies just visible behind heart, inspiration adequate, 6 anterior ribs visible, rotation, the patient is slightly rotated to the right. Airway, the trachea is central after factoring in patient rotation, breathing, there is left lower zone space opacification with loss of clarity of the left heart border. The lungs are otherwise clear. The lung are not hyperinflated. There is biapical pleural thickening and blunting of the left post-pharyngeal angle in keeping with a small diffusion, normal pulmonary vascularity. Circulation, the heart is not enlarged. The left heart border is indistinct. The right heart border is clear. There is a retrocardiac mass which has the density of gas. The aorta appears normal. The mediastinum is central, not wider and clear borders. Normal size, shape and position of both hilar, diaphragm and dedicates. Normal appearance and position of the hemidiaphragm. No pneumoperitoneum. The image skeleton is intact with no fractures or destructive bony lesion visible. The visible soft tissues are unremarkable. Extras and reduced areas, no vascular lines, tube or surgical clips. Lung emphasis by apical pro-thickening, hilar normal, behind heart retrocardiac gas field opacity, costophrynic angle, blunted left costophrynic angle below the diaphragm normal.
So to be honest with you, lama tak perasan. Tak perasan. Stuff for me. Bad apical pleural thickening stuff. I mean, chances are going to miss this. Itis ni aku tak miss lah. Cuma Rosita clear tak payah tengok, tak payah tengok tu. Tahu. Tapi lelaki tak miss retrocardiac man.
Tapi
tak tahu apa dia benda lah.
Tak sure.
Macam benda. So which lobe is affected? Left lower lobe kan. Kalau the superior border of the left heart is affected, it's lingula. Right. So this is left lower zone. Lost clarity. And then aku contest ni dia kata this X-ray in keeping with lingular pneumonia. Aku kata that the superior border is not affected. Superior border aku lingula. Jadi dia kata lingula. No. Okay, any heart border is obliterated, you can say lingula. But for me, lingula is more like heart border, upper border. Okay? We'll stop here. So, what do you learn today? Start with you. Left upper lobe collapse. Features left upper lobe. Cardiac. This one? Yeah, pleural fracture and hiatal hernia with. When was the last time we stopped? Berapa kali kita stop? 7 September. Now it's 3 bulan, almost 3 months. Stop, never start. After that, aku try go with plain belly filler. What is happening? But there's another 3 more happening. This belly film. Belly film is a bit tricky. Yeah? Contrary to people believe, it's easy. No, it's not easy. And those buckets who knows well this plain belly film, which is supposed to be the surgical bucket. What? Suppose aku argue, the ED bucket should know. Radio they report every day. Nobody can beat radio. Cannot you beat radio too? Cannot beat la radio. Say hari-hari dia tengok. I keep saying you know, don't feel like disadvantaged being in ED. You don't know. You should know better than them. Itu aku kopi.